Okay, so again, my name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan, and this Learn and Share conference call is entitled Diagnostic Tools for Epilepsy from EEG to PET. And I'm going to be talking about all of those acronyms and the whole process of diagnosis. Our guest speaker today is Simon Glynn, Dr. Simon Glynn from University of Michigan Health System's Comprehensive Epilepsy Program, and we're very pleased to have him with us. Dr. Glynn, can you just introduce yourself a little bit and give us an overview of your experience at the Comprehensive Epilepsy Program at U of M and your experience with this particular topic?
Of course, and thank you for the invitation to the call.
Sure.
I have been at the University of Michigan for 3 years and am in the epilepsy group at the University of Michigan. I did neurology residency at Mayo Clinic in Rochester, Minnesota, and have done several epilepsy fellowships. I did one with the group at Mayo Clinic and then moved to Philadelphia and did an epilepsy fellowship with some people there, some of whom are very prominent and helpful in advocacy for patients with epilepsy. Jackie French was my supervisor there. Mm-hmm. And then did a neurosciences fellowship through the University of Pennsylvania, specifically in neuroimaging and fMRI. My interest in imaging was something that I had really probably before I went to medical school, but the question of imaging and how it could best be applied to help people with epilepsy was something I became very interested in at Mayo Clinic. We had very good imaging there, and they had developed a specific type of imaging that's now widely used called SPECT imaging or SysCom imaging. Mm-hmm. And I was quite taken with how helpful that was and had wanted to learn more about how to apply imaging, so that led me to do these other fellowships. And as I said, I've been at the University of Michigan here for 3 years. My interest, as you would guess from what I just said, is in epilepsy, of course, but specifically trying to find ways to bring more information to the care of individual patients, both before surgery and for the planning of epilepsy surgeries. Does that answer your question, Russ?
Absolutely. Okay, so before we start talking about EEG and neuroimaging technologies, can you talk about some of the other steps involved in the diagnosis of epilepsy? It's easy to get caught up in all of the technology and the neuroimaging and the tests, but there are some other important aspects of diagnosis. So can you tell us about some of those different approaches to diagnosis?
Sure. So the tests probably have no role until you can take care of some other things, and two questions need to be answered. Of course, the first is whether someone has had a seizure, and the second question is whether they have epilepsy. So a seizure, of course, and I think probably everyone on this call knows, a seizure is an electrical event in the brain. Mm-hmm. So we think of seizures as being events where people fall down, shake, and convulse. And many people do have that seizure type, but most people actually will have a different seizure type, and it can be quite subtle. Those smaller seizure types are often very individual, very unique to the person, like a fingerprint. But if seizures, then all those things are happening because of a change in the electrical activity of the brain. So that's what a seizure is. Epilepsy is a condition in which people have a tendency to have seizures. So the point being this: you can have a seizure for many different reasons. Epilepsy is a different diagnosis. It's a diagnosis that's given when someone's history suggests that they have a tendency to have seizures, and specifically seizures for which there isn't another good explanation for why it happened. So to give one example, the person is not someone who drinks alcohol regularly, stopped drinking 24 hours ago and had a seizure. In that scenario, you might diagnose a seizure, but your suspicion would be that it related to the person's habit of drinking and not drinking. Epilepsy is a different diagnosis. It's a diagnosis given where people have seizures for which there isn't a good explanation. So the history is critical, and in fact it's commonly the case that the history is everything in seeing a patient with epilepsy, and that the neurologic examination and general medical examination are normal. That's not always the case, of course, and so the second part that's important is a detailed medical review and neurologic examination. If you find things on a medical review or on a neurologic examination, for example, some people might have weakness on one side, or they might have distinctive changes on their skin. Those things, although it might not seem intuitive to people on the call, those things can point to specific types of brain dysfunction that could predispose someone to seizures. So a history and a physical. And then it would be wrong to say that EEG isn't also a central part of diagnosing seizures and epilepsy, because I think most patients for whom this question comes up will receive that test as an initial test, and will receive some imaging also before the diagnosis is given.
Right. So what in the process of diagnosis, what are some things that patients and their family members can do to help doctors during this process?
Yeah. So probably the most helpful thing would be to come to the clinic visit. So I say that not to be clever, but simply because many people who have seizures simply can't provide a good narrative for what happens to them during a seizure. And there's nothing more frustrating than seeing a patient who's there and clearly needs help, but is unable to provide you with any of the details about what happens to them that would allow you to really weigh in and be helpful. If it's not possible for family or friends who have seen events and can describe them to come to a visit, then they should provide a phone number and be available on a cell phone, for example, for someone to call them and ask questions. Questions that you will be asked are what happens during a seizure, and in some ways it's an unfair question because we're asking you at a level of detail you wouldn't usually give, but that's mostly the interviewer's responsibility, not yours, to help you with that. The other question you'll be asked is, how long do the seizures last? Yeah. And that's very difficult, because if you've seen someone you care about have a seizure, the answer is it seems like it lasts forever. But it is important to know how long seizures are lasting. So if you have someone whom you care about that has epilepsy and you've seen them have seizures, it is very helpful to know how long the seizures last, what their behaviors are before, during, and after the seizure, and how often they're having seizures. Those things are all very important.
Yeah.
And Russ, if I'm not answering your question at any point, just interrupt me.
Oh, sure.
Redirect me.
Right.
Okay.
And what are some of the most common conditions that can be confused with epilepsy that you may have to rule out during the diagnostic process?
So there certainly are other conditions that can be confused with epilepsy or seizures, and the common ones would be first, fainting spells, or syncope is the medical term. You would think they would be easy to separate one from the other, but as it turns out, they're actually they overlap quite a lot. Mm-hmm. And there have been studies done that have caused young, healthy medical students to faint, and they've recorded it on video, and actually almost everything that can be described in an epileptic seizure was apparent on those video recordings of young people having fainting spells. So that's the first thing. The second thing can be any medical illness that might affect blood flow to the brain or affect alertness and cognition. So blood flow to the brain depends on your heart beating well and your blood vessels being open and perfusing your brain well. It's rarely the case that those conditions are confused with seizures, but we pay attention to it because those are possibly life-threatening conditions. Any medical condition that affects your thinking can be confused with seizures. So sometimes people will have medication effects or an underlying medical condition that causes fluctuations or changes in their thinking. Mm-hmm. And the question comes up, is the person having fluctuations or are they having seizures that are causing these changes? And then a last group that is maybe surprising or maybe not surprising to your listeners would be people that have movements that are indistinguishable from epileptic seizures but are in fact not epileptic seizures, and the explanation for those is that they're related to stress.
Right.
So-called non-epileptic spells.
Right.
Okay.
So another person just joined us. Who just joined us?
Brian.
Hi, Brian.
Brian Nichols.
Okay.
Hi. Sorry, I was having a hard time accessing.
Oh, did you just get my email?
Yes, I just got the email.
Okay.
Yep. Actually, I have Mary Harvey here also, and we've been trying to log in through hers, and so we've been having issues. Sorry about that.
Okay, you're both on now? Okay, great.
Yep.
Great.
She actually just stepped out for a second, but yep, she's here too.
Okay. So let's talk a little bit about EEG. It's probably the diagnostic tool most people think of when they think of epilepsy. And can you give a quick overview of the different types of EEG and when they're used and then what they show?
Sure. So EEG, the longer word is electroencephalogram. It is the imaging or functional test of choice for epilepsy, and it's an old technique. It was developed in the late 1920s. To understand why it's important, you have to at least be clear about some basics. So just to be clear, the brain works on chemistry and electricity. It does not have moving parts. It uses chemistry to make electricity, and it's electrical current that allows the brain to do what it does. And we can certainly have a conversation about why it works that way, but what is clear is that who you are and what you're able to do, your memories, your dreams, are all encoded in that electricity and chemistry. So when an EEG recording is done, they place wires on your head, and that machine actually is doing nothing to you. What the technologist is doing when they place the wires on your head is they're building an antenna, no different than a TV antenna. They're building an antenna on your head, and that antenna records electrical activity generated by your brain during the 30 minutes or so of the EEG study. And when you do that recording, you can look at the data in many, many different ways, but irrespective of how you choose to look at the data that comes out of the recording, what you see are rhythms. So the brain's electrical activity generates rhythms, and there are accepted patterns of normal rhythms. So we expect to see at the front of the head and the back of the head certain types of rhythms in certain frequencies, and those descriptions all together are what amounts to a normal EEG recording.
Dr. Glynn?
Yes.
It sounds like to me that you feel EEG you said began in 1930s. Do you feel that it's still old, or do you feel that there is something better out there other than the EEG?
So I'm a big fan of EEG, but even if I weren't a big fan of EEG, I think it still is the test of choice for epilepsy. But there are many circumstances in which other tests are helpful, and I think we'll probably end up talking about that. So when you do an EEG recording, you're recording electrical activity, and we had said that a seizure is a change in the electrical activity of the brain. So the first thing that can happen is if you happen to have a seizure during an EEG recording, there will be a change on that recording. And depending on the type of change, it can help your doctors be clear about what type of epilepsy you have, where your seizures start in the brain. Most people don't have a seizure when they're having an EEG recording, and so instead what the person reading the study is looking for are what we call interictal changes, interictal meaning between seizures. And these are telltale changes on the recording that we see in people who have a tendency to have seizures. We call them interictal epileptiform discharges or abnormalities. They're sometimes called spikes, they're sometimes called sharp waves, they're sometimes called spike and wave, and these are all just descriptions. These are not seizures, but they're electrical changes that suggest that the person who's having that recording has a tendency to generate seizures. So that's what an EEG does. Most EEGs are 30-minute studies done in an outpatient laboratory, and the yield on that in terms of finding something that suggests a person has epilepsy is probably on the order of 60%. The next study that is used is what's called a sleep-deprived EEG, where you ask someone to limit the amount of sleep they have before the EEG recording. And the whole point of doing that is that they fall asleep during the EEG recording. And for reasons that aren't well understood, some types of epileptiform abnormalities, so those telltale signs we were talking about, they're more apparent when someone's sleeping than when they're awake. A sleep-deprived EEG is a little more involved because the person has to stay up. It's usually in the morning, and the recording is also a little longer to allow them to fall asleep. Two other types of EEG you can have would be first an ambulatory EEG, where they put the wires on your head, send you home with a box, usually attached to a waist pack, and that records EEG continually for somewhere between 24 and 72 hours. Some centers will even send you home with a video camera as well. That test has advantages and disadvantages. The advantages are that it's recording you in your normal environment, and some people have frequent seizures in some circumstances, but simply don't have them when they're having an EEG study or if they're in hospital. So it can be very helpful to record frequent seizures that seem to be circumstantial. For example, when I first wake up in the morning, I always have a seizure. One way to study that is to give the person an ambulatory EEG and look at the recording at the time they were waking up. The problem with ambulatory EEGs is there's usually no video record that goes with it. So the person reading the study is looking at a diary you wrote down where you said, 11:45 I had my event, and they're looking at 11:45 on the record, and it may or may not be clear to them whether that's a seizure. The other problem is that they tend to have a lot of technical artifacts. EEG is very technically difficult, and sending someone home for 3 days, you'll have a lot of poor quality in the recording. And then the last type of EEG recording is where people are brought into hospital for video and EEG recording, and that is done usually with the goal of recording their clinical events.
That's what I had done.
You know, I've done that myself a few times.
Russ, does that answer your question?
Yeah.
Okay.
And then the other types of EEGs, like the subdural and depth EEGs, and
those
are primarily for pre-surgical evaluation.
Yeah. So thank you. So everything we just discussed is a variation on the same technique, where wires are put on your head and you do a recording. There are some specialized EEG techniques where instead of doing the recording by putting wires on your scalp, we put the wires directly on the surface of the brain. And that is only done after people have had detailed scalp EEG recordings, and it's only done in one area of the brain. You can't cover the whole brain with recording electrodes. It's done when someone is being considered for epilepsy surgery, and you need to be very clear about where their seizures arise, because you're considering removing that area, and because you need to test brain function in that area. And I don't know if we want to talk about this, but those electrodes that you place on the surface of the brain can also be used to test for function. Those are the two questions that have to be answered before someone can have some types of brain surgery. First, do you know where the area is that you intend to remove? And if you do, can you convince yourself that you're not going to harm the patient by doing a surgery there?
Right. What types of special training is needed to correctly read an EEG? I've heard a lot of reports of EEGs being either over-interpreted or under-interpreted by doctors who aren't sufficiently trained. Is that something that you run across often?
Tricky question. It is a problem. It is a problem. Most neurologists in the course of their residency will do a rotation where they're taught how to read EEGs. So most neurologists will be able to interpret an EEG. If people intend to do that routinely, for example, seeing patients who may have epilepsy, they usually will have done some additional training, a fellowship in clinical neurophysiology, for example, which is 1 year. At some centers, it's 2 years. The more training you do, the more the expectation is that that's what you'll concentrate your career on after you finish that training. It's certainly the case that the more experience you have, the better your EEG readings are. Most of what someone sees when they look at an EEG recording, if you have no training in EEG and you look at the screen, most of the things you will point out will be artifact, meaning that the things that you will notice that you'll point to will either have nothing to do with the person's brain activity, or there'll be technical problems on the recording, or there'll be normal things that everyone does that aren't of concern. And that's just the nature of the study. So the more you've looked at the recordings, the more you recognize those things as being normal or of no concern, and you look past them. The second area where there's a little controversy is in under-reading or over-reading EEGs. There are quite a few things that are what are called normal variants. Normal variants means that these are things that catch your eye and in some respects appear concerning for underlying brain dysfunction or a tendency to cause epilepsy, but in fact they're normal. They're just variations on normal. And we know that from doing recordings since the 1930s on people with all sorts of conditions, that we can see these normal variants. There are some normal variants that notoriously get misinterpreted by some people as signs of epilepsy. And in fact, when you review their EEG recordings, it's clear that they're normal variants. But then, just to be fair to my colleagues, there are areas, there are EEG recordings, and especially EEG recordings in people that are sick. so people in ICUs, for example, where very well-trained EEG readers will disagree about what the implications are of the recording. There is a spectrum of opinion that covers some types of recording, and I wish that weren't the case, but it is the case. And I can tell you that I've had recordings where a who's who of people have looked at them at national meetings, where the patient was being recorded, and the question was, were they having seizures? And the best consensus you could get from 3 of the top people in the field was, I think probably this isn't a seizure. So it gives you the sense that there are some recordings that can be quite difficult.
Right. If a person's EEG is normal during a videotaped episode, which often happens, does that necessarily mean that the episode is not an epileptic seizure, or are there sometimes situations where the abnormal electrical activity is too deep, or is not picked up, or is distorted somehow, or otherwise missed?
Mm-hmm. If someone has had video EEG recording of their clinical events, and it's a good example of their clinical events, then usually the results of that test are correct without any caveats.
Okay.
Meaning that if someone has an event and the EEG recording is normal during that event, then it means that event was not an epileptic seizure. So just to revisit the point, we said that seizures are a change in the electrical activity of the brain. So if you are recording on video and EEG at the same time and capture someone having an event and the EEG recording is normal, then that's not consistent with an epileptic seizure. Now, there are some caveats, though. So the first is that very mild events, and events where someone's alertness isn't impaired,
yes,
can be not recorded on EEG.
Mm-hmm.
So a very mild event can have an electrical signature that is so subtle that it's not seen on EEG. Very rarely there are persons that will have types of seizures coming from the frontal lobes where, although the seizure is not subtle, it's very dramatic, you don't see an EEG change. In those cases, though, the problem is often that they're moving so much during the event that the EEG recording isn't interpretable.
Oh.
So it's not that the EEG is normal, it's that you can't see anything on the recording because of how violent their event is.
Mm-hmm.
I think if these studies are done well and they're done by people that are good at interpreting these data, then I think it's seldom, if ever, the case that those 2 caveats don't get picked up.
Right.
So if you have the privilege of recording someone having their events on video, if the EEG is normal, you still can raise the question of seizures. You have that opportunity as the person reading the study to raise concern for seizures, and there are some cases in which we do that. But it's usually apparent after speaking to the patient, examining them, and recording good examples of their events, who those people are.
Other than pre-surgical evaluation, when should a person who's already been diagnosed with epilepsy get another EEG? Are there circumstances where it's good to get another one? If you've had epilepsy for 5 years or something, is there a routine time when you would get another EEG, or are there special circumstances when you'd want to get a new EEG?
Mm-hmm. Good question. So different people will give you different answers to that question. The strict evidence-based answer would be it's not necessary to get another EEG unless you have been seizure-free for a prolonged period of time and you and your doctor are contemplating reducing or stopping your medicines. Mm-hmm. So it is the case that for many people, certainly not all, but for many people, their seizures go into remission. and it's not clear that those people do need medicines. So at some point, if you enjoy a long period without seizures on medicines, the question comes up, do you still need the medicines? And at that point, most doctors who do epilepsy will want another EEG recording. They will want that recording because if the recording shows, again, a clear tendency to have seizures, then there'll be less enthusiasm for counseling you to take off the medicine. Right. If the recording is normal, of course, it doesn't tell you what will happen. It could be that you would not have seizures. It could be that you would. A normal recording in that context isn't very helpful. An abnormal one probably is. There are other people who like to get EEGs on their patients more frequently, and there's it's so common clinically for doctors to do that I hesitate to say that it's wrong. I don't think it's wrong, and I can give you, for example, one scenario where it's very helpful. So patients with idiopathic generalized epilepsies. So that's a type of epilepsy which is diagnosed based on an EEG recording. Their EEGs can become completely normal on medicines, and when you see that, it encourages you that the medicine is well chosen and correctly dosed. If conversely the EEG recording shows very frequent activity, you might change the medicines depending on the specifics for that patient. So someone with an idiopathic generalized epilepsy is someone where one might get recordings other than the question of withdrawing medicines. And then, of course, if anything is happening to the person where the question is whether they might be having seizures or might be having medication side effects, that would be another scenario, in which case you would get another EEG.
Or
I just had one last week.
If someone's seizure patterns have changed suddenly, or they start having more seizures for no apparent reason, would that be another circumstance when you might have another EEG?
It's a common circumstance in which an EEG will be ordered, but equally, depending on the details of the case, someone might not choose to order another EEG. Okay. So, for example, if someone's been well controlled, runs out of medicine, and has a flurry of seizures, almost certainly you know what happened there, and an EEG recording isn't necessary.
Right. Does anyone have any, before we move on to other types of the neuroimaging technologies, does anyone have any last questions about EEG?
Yes, I do.
Okay.
Yes, I do. I was told that I have epilepsy and panic disorder. Mm-hmm. Now, what does panic disorder, what does it, because you were saying non-epileptic seizures, is that a non-epileptic seizure? Panic disorder?
Mm-hmm. So, and again, I want to just be very careful that I'll answer the question, but I don't know if this is correct for you because I don't know you, and it would be stupid. It's a fool's game to try and diagnose people over the phone.
Okay, over the phone.
But a panic disorder refers to a condition in which people feel suddenly symptoms of panic, and it is not a seizure disorder. Mm-hmm. It's actually a quite common condition, and usually can be treated with medicines. Sometimes patients will be recommended to do cognitive behavioral therapy with a psychologist.
Yeah.
If you're asking the question, can patients with a seizure disorder have symptoms of panic? They can, and it can be related. It can either be simply that the impact of having a seizure disorder and the stress that imposes on them leads to panic, or there are some seizure types that can present as panic attacks.
Now we're going to get into some of the other acronyms and try and get through as many of these as we can.
Okay.
MEG or MEG or magnetoencephalography. it's similar to EEG, but very different in several ways. Can you discuss about how it's different, how it's similar, and then what it's used for?
Sure. So you can't see me because we're on a telephone conversation. If you were seeing me, I would be waving my hands as we describe these things, because we can't take it to the level of science on the phone. So I'm waving my hands as I say this. If any of you are physicists or electronic engineers, you'll cringe at some of what I say, and feel free to jump in, and we can modify it a little bit. So Meg is Russ is correct. Meg is very much like EEG. Meg depends on a fact of physics, which is that when you have a current, you have a magnetic field. So we said your brain works on electricity. That means that those neurons in your brain are creating currents. That means that your brain, in addition to creating electricity, also creates a magnetic field. And using very sensitive and very, very expensive equipment, you can actually measure that magnetic field generated by the brain. To do that requires a detector that's called a squid, if you can believe it or not. And the way you record the magnetic fields in the brain is you use a helmet that rests near the head, but not pressing on the head. And attached to that helmet will be something on the order of 250 to 500 of these squids or detectors. And that whole apparatus will be positioned in a room that has the harmonic features of a perfect crystal. And if you do all of that, which costs several $1 million, you can record the magnetic fields generated by someone's brain. So those magnetic fields are very much like the electrical fields, except they have some differences. Electrical fields that we record with EEG are blurred a little bit by the skull and the skin that's in between your brain and where we're recording. And the magnetic fields don't really care about that, so they penetrate much better. And the other two advantages to MEG are that you have a lot of channels. So when they do an EEG on people, a routine EEG would be somewhere between 16 and 23 of those little wire discs. And when you do a MEG, you use 500 detectors. And when you use that many detectors, it allows you to do some mathematics and say where you think the generator is for things you're seeing on the recording. So remember, we said on an EEG you see these telltale traces, and you can usually on EEG say, I think, for example, this comes from the left temporal lobe, or this comes from the right frontal lobe. With MEG, using the many detectors you have and some clever mathematics, you can usually, within a centimeter or two, half an inch or two, you can say where a generator is. Now, there are some caveats to all this, though. The first is that that's just an estimate. So it's a very seductive, pretty picture that a MEG paints, and it can be very useful, but it is a mathematical model of where the seizures are generated and not always correct. The second thing is that a MEG isn't really very portable. So you go to the MEG doesn't come to you. So it's a technique that is pretty limited in terms of how it can be used because of its cost and because of the equipment required. And then the third is that there are some things that MEG does that you can do with EEG, and sensors have just been slow to do it. So, for example, you can actually do an EEG recording with 250 channels. You just need to do it in a way different than gluing each of the discs on. The way you've had an EEG, the tech glued each disc on one by one. You can't do that for 250 discs. You have to have a different technique. There are companies that have that, and maybe or maybe not over the next 10 years we'll start to see that used more in epilepsy care. So a MEG is complementary to EEG. Sometimes it gives you information you did not have on your EEG recording because of some technical differences. But its application is, on the other hand, a little limited simply because of how exotic the equipment is.
Right. And how
that answer your question?
Yeah. How widely available is it? Can you get it done in Michigan, or is it only a few centers?
So the person who runs the MEG laboratory at Henry Ford Hospital is Greg Barkley, and we routinely send patients to him where we think that test would be helpful. It's been very complicated, though, I should say. I mean, the caveat on this is until 6 months ago, no one would pay for it.
Right.
So what it meant was that the only way you could get this study was if you were enrolled in some sort of trial or being done at the center that had the MEG. But there's an agreement in place in the last 6 months that allows insurance companies have agreed to start to reimburse for this. And so it is possible for your doctor, for example, to refer you, if that's appropriate, for a MEG study. And in southeast Michigan, Henry Ford has a very good MEG laboratory.
Right. So MRI, or magnetic resonance imaging, is probably the most widely used neuroimaging technology in diagnosing epilepsy. Can you give, again, a brief overview of MRI, when it's used, what it shows, and also talk a little bit about the different strengths of MRI machines and what impact that has?
Sure. So now I'm really waving my hands. If you can't see that, now we're really waving our hands. So MRI is a fabulous thing, but it's a little difficult to explain. And for whatever it's worth, I mean, it's not rocket science, but it's more complicated than rocket science. And the only people who really have a deep intuitive understanding of MRI are people who do quantum physics. So everything we're going to say is sort of hand waving. But MRI is different than any other kind of imaging. You know, most people think of X-rays when they think of images, and the idea with X-rays is that some particles come out and they pass through you, and they pass through some things easily and some things less well, and that's what gives you your X-ray picture. MRI is different. MRI is looking at water molecules, and specifically it's looking at hydrogen atoms in water molecules, but it's looking at water. So MRI is a way of taking a picture of water, and it turns out that water is everywhere in your body in varying concentrations. So obviously in your blood you have a lot of water, but in tissue you have a lot of water, and the concentration of water is different depending on different tissue types. And when you have an injury, one of the things that usually happens is you get some swelling or edema. So that's also water. So MRI looks at water, and water is a clever way of looking at different tissues in the body and the brain. So the way an MRI does this is it's a huge magnet, and your body gets put into this huge magnet. The magnet does nothing to you, although if there's anything metal on your body, it will get pulled by that magnet. But the magnetic field itself causes no harm. We do MRIs routinely in newborn babies for clinical trials. So the magnetic field is safe. So you're in this magnetic field, and then a little generator gives a pulse of energy, which is very low frequency energy, much less energy than you would get with a dental X-ray, for example. It gives a little pulse of energy, and then an antenna listens for the signal back. And that's how it makes a picture. So the way to think of MRI is the machine is huge, and when you've seen an MRI, you lie on a table and you slide into a big ring. That's a closed MRI. That big ring is a magnet, and it's just on all the time. When you hear that banging noise in the MRI, that's those little radio frequency pulses being sent off. And then the rest of the machine is a big antenna. And the way to think of MRI is as a very sensitive antenna. Other imaging techniques involve a lot of energy. MRI involves almost no energy. It's just a very, very sensitive antenna. So you use that machine to take a picture of water molecules, and it turns out that doing that, you can take beautiful pictures of the brain. In fact, MRI is far and away the best way to take a picture of the brain, and MRI is recognized now as sort of standard of care when someone is first diagnosed with epilepsy. And you can do some tricks with that MRI signal that allows it to do some clever things. So by doing one kind of trick, you can look for brain activation, brain activity, so-called functional MRI. And by doing another trick, you can look at fiber pathways in the brain, and you can actually start to make pictures that show how one area of the brain is connected to another area of the brain. You can actually take a picture of the brain, put a pointer on an area, and say, show me all the areas to which this is connected. Wow. And there are still some other tricks that can be done with that signal, but all of it starts with this technique for taking a picture of water molecules. How's that for a...
Excellent.
Too deep, too superficial?
No, that's
yeah,
great.
Okay.
And the different strengths of MRI, and I know a lot of people.
Oh yes, right. So
will say, well, we
yeah,
have
so right. So right. So the clinical standard now is either 1.5 Tesla or 3 Tesla magnet, sort of a meaningless number to you. And open MRIs are used to be 0.5 Tesla. Tesla refers to the strength of that magnetic field. So remember, we put you in a magnetic field. That strength varies. Open magnets tend to have lower strengths and take less good pictures than closed magnets, which is why, for example, we don't have an open magnet, and many centers don't. Because the pictures are less good. They've improved in the last generation of scanners. What's a Tesla? A Tesla is 20,000 times the Earth's magnetic field. So a 3 Tesla magnet, when you're in a 3 Tesla magnet, you're in a magnetic field that is 60,000 times the Earth's magnetic field. The Earth's magnetic field is what makes your compass point. And what does that mean? So if you were to take a cookie sheet and hold it in your hand and walk slowly, and don't do this, by the way, please don't do this, but if you were to take a cookie sheet and hold it in your hand and walk towards an MRI machine, by the time you reach the foot of the table, you would feel that cookie sheet starting to move in your hands.
Wow.
And by the time you were halfway up the table, but not to the head of the bed, that cookie sheet will be frozen in space, meaning you could put all your weight on it and it's not going to go anywhere. You would not be able to twist it from side to side. The magnetic field is so strong. And if you get any closer, it'll pull you right off your feet and pull you into the magnet.
Oh, wow.
So it's a very strong magnetic field. But if you've ever had an MRI, you also know that you don't feel it. It's not something you experience or feel. And the effect of that magnetic field is so vanishingly small on the body that it's hard to believe that you can get any useful information out of it at all. And I'm not sure I can explain it on the phone, but when you put someone in a magnetic field, what it does is it makes water molecules. It makes nuclei, but let's say water molecules. It makes them line up one way or another. They either point up in the same direction as the magnetic field, or they point in the opposite direction. And you would think that they would all point in the same direction as the magnetic field, and that turns out not to be the case. So if you had 1 million water molecules pointing down, you'd have 1,000,004 water molecules pointing up, and that difference of 4 molecules is enough to make the MRI picture that your doctors look at.
Wow.
it's a pretty unbelievable technology.
Right. So
I can sleep through the MRI.
I have a question. If you have a VNS or a pacemaker or something, what are the restrictions there? Because it is metal.
You're correct. So there are restrictions on all devices. So for VNS, you are able to get MRIs of the brain with the VNS in. The VNS is supposed to be turned off before the picture is taken and then turned back on. And the only MRIs you can have are of the head. You can't have MRIs of the rest of your body. And the reason you can't have MRIs for the rest of your body is that no one has done a study showing that that's safe. So it may be safe, but no one's done a study showing that it's safe. For things like defibrillators and pacemakers, it's a real problem. In Europe, there may be more current data than this, but a few years ago in Europe, they did actually do a small series of people who had pacemakers, and they did fine. There was no dysfunction. The pacemaker wasn't damaged. The person wasn't damaged. But I'm not aware of any centers in North America that will do an MRI when people have a pacemaker or a defibrillator in place. And the concern is for damaging the device or hurting the patient when they're in the magnetic field.
And isn't there a limit to the Tesla when you have a VNS? And why do you have to turn it off? You're
very good. So there is a limit. You're limited to 1.5 Tesla, which is an excellent picture for all intents and purposes. There are few circumstances where 3 Tesla is more important. So 1.5 Tesla, and if you ask me why 1.5 Tesla, the answer is that Cyberonics has not completed a study at 3 Tesla to show that it's safe. There's no reason to think it wouldn't be safe. It's been done at 3 Tesla, but they have not done a study, and so it's not approved for use at 3 Tesla. And the device is turned off to minimize any effect on the device itself, not because the device will hurt the MRI machine, but to make sure that there's no electrical current from the device while it's in the magnetic field that could damage the programming of the device. Does that answer your question?
Yes.
Right.
Okay.
But only of the head. MRI only of the head.
Yes.
Right. Under what circumstances would a CT or computed tomography scan be used instead of or in addition to an MRI?
So a CT scan is an excellent picture. It's using radiation, not magnetic fields, and is usually the imaging that you receive if you're in an emergency room. So with a few exceptions, emergency rooms have access to CT scanners and not MRI scanners, or not quickly MRI scanners. So if there is a clinical question about why something has happened to someone, so if someone arrives in an emergency room and they're not alert, or they're not moving one side, or they've just had seizures and they've never had seizures before, that person will get a CT scan. And the reason is because a normal CT scan excludes quite a number of worrisome things, and those worrisome things are seen on CT scan. So if something urgent needs to be done, it's usually apparent on a CT scan.
Okay, great.
And can people with VNS get CTs?
Oh, yes, yes.
And what would it show about epilepsy?
Well, that depends. So some people, for example, have very slow-growing tumors that can cause them to have seizure disorders. Mm-hmm. Some people have changes in the formation of their brain that happened well before they were born that would be apparent on a CT scan. Some people have been in car accidents and had brain injuries that predisposed them to seizures, and that brain injury would be apparent on a CT scan. Those are examples.
Mm-hmm.
Okay. So MRI and CT scans look primarily at the structure of the brain, but there's also several tests that can help look at the brain's function. Can we talk about some of those? Let's start with PET, or
sure.
positron emission tomography.
This is turning into a real seminar. You're setting the bar high. So there are several functional imaging. So that's right. So an MRI or a CT is like a photograph of the brain. It's like taking a photograph. It tells you nothing about how the brain works. If the brain wasn't working at all, it will look the same in the picture. So the functional techniques are PET, SPECT, and fMRI, and it may be that Russ has a few other clever ones that he's going to spring on me. We'll see. So PET is, all these techniques were developed in the late 1970s and really changed completely the way we study the brain, because before that, the only functional imaging technique you had was EEG. And that is, after all, a functional imaging technique. It doesn't give you a picture that looks like a brain, but it is a functional imaging technique. So PET is positron emission tomography. It is a nuclear medicine study where you give someone an injection with a radioisotope, and that radioisotope is tagged to something of interest. So let's say, for example, that you wanted to know which parts of the brain are involved in speaking.
Yes.
So you would say, all right, so I'm interested in the parts of the brain that are involved in speaking. I think that when someone speaks, those parts of the brain will work harder because they're speaking. And when the brain works harder, it uses more oxygen and it uses more glucose. So glucose and oxygen are the fuel that run the brain. So what you would do with a PET is you would give an injection of a radioisotope, and you would tag that radioisotope to molecules of glucose or molecules of oxygen. And then you would tell the person, you would give them the injection, and you would tell them to start talking, and you would then take a picture over 40 minutes while they're talking, and what you would see is where that radio tracer went. Remember, the radio tracer is tagged onto glucose molecules, so it's going to go where glucose is being used most heavily. And if they're talking, it'll go to the areas of the brain that are responsible for talking. So it's a way of making a functional picture. You can get a picture that shows you, for example, these areas of the brain light up when someone talks.
Oh, wow.
Yeah. So it's a nuclear medicine study. The scan requires an injection. Some scans require taking serial blood tests while the scan is going on, but most don't now. And the study takes probably an hour and a half when all is told. Here we always do an EEG with the study, and we want the EEG to be running for a little while before the person goes. So it's here getting a PET is about a 6-hour undertaking for the patient. There are different kinds of PET studies you can do. For epilepsy, the only clinically used study is the one we just talked about, a glucose uptake study. So looking at brain metabolism in between seizures with PET is very useful for detecting some types of epilepsy. You would not do this test to answer the question, does someone have epilepsy? You would do this test if you know they have epilepsy and you're trying to be clear about where in the brain their epilepsy starts.
Okay.
Is that okay, Russ?
Yes, perfect.
Yeah. Lots of other clever studies that you might run into at a center that does clinical trials. So here we have something like 17 different things that you can tie that radionucleotide to, and they're doing all kinds of studies. But the common one you would run into is glucose.
Okay. And
see, that's what I need because of the neurofibromatosis. Is because I don't know if my tumors are a result of the NF or a result, if they're, of a seizure or something,
Mm-hmm.
And my doctor is, Dr. Smith would be the only doctor that would ever answer my question, if I would see him.
Dr. Smith is a very so I want to speak.
I always see him in May at the Epilepsy Foundation breakfast.
Dr. Smith seems to be a very well-liked and certainly is a very well-respected epilepsy doctor.
Right.
It's a shame you left. It's a shame you left the area.
Yeah.
Not a shame if you're in Grand Rapids.
Right.
Okay.
Yeah.
Can you talk now about SPECT?
Sure. So SPECT developed around the same time. Similar idea, except instead of positrons, you're looking at something called photons, which is a unit of energy when a nuclear particle changes its state. So forgetting what I just said, it's a similar kind of study. So you have a radioisotope, and you tag it to a molecule, and you inject it, and what SPECT is used for is to map blood flow. So PET can be used to map all kinds of things, but SPECT is used to map blood flow. So the thing you attach your radioisotope to is something that just travels in the bloodstream, and where you have a lot of blood flow, it will go there, and where you don't have much blood flow, less will go there. Mm-hmm. So you do the injection, and then you take a picture. SPECT, the picture you get with SPECT is much less good than the picture with PET, and both of those are much less good than MRI. The reason SPECT is used is that you can actually do this test when someone's having a seizure. So this was the technique developed at Mayo Clinic. They would wait for someone to have a seizure and do an injection of the radioisotope at the time someone's having a seizure. You then wait for the seizure to end, and then within 2 to 4 hours, you take the person downstairs to the SPECT camera and take a picture. And what that gives you, that picture is a map of blood flow at the time of that seizure. And remember, we said when the brain's doing things, it uses more glucose and oxygen. It also has more blood flow in that area when it's doing something. So the idea is that a SPECT image taken when someone's having a seizure will show an increase in blood flow in the area that's driving that seizure. And what you usually do next is you take a second picture at least 24 hours later when someone isn't having seizures. And you put the two pictures side by side, and you ask, where was blood flow increased at the time of the seizure compared to this normal study? And that's the idea behind SPECT. So we do that here quite a lot. And the way we analyze the images is using a statistical analysis. We normalize the images and overlay them and calculate statistics on each voxel in the image, looking for difference maps. And then we fuse that functional map to a person's MRI. So you get both the structural information from the MRI and you get the functional information from the SPECT.
Okay.
And why can't PET be used during seizures or shortly after seizures? Does glucose metabolism not affected by seizures?
Glucose metabolism is affected by seizures. The problem with PET, well, there are two problems. The first is SPECT can be done at the bedside. So logistically, it's very complicated. But if you can arrange for a technologist to sit day after day by a patient's room and wait to do an injection at the start of the seizure, if you can do that, then you can do a SPECT injection. To do that with PET would mean spending day after day in the PET camera waiting for a seizure.
Right.
So that's the first problem. The second problem is that when you inject the SPECT tracer, it's a first-pass uptake, meaning you inject it, it goes into the brain, and it's all uptaken within probably 30 seconds. With PET, the acquisition's over about 40 minutes. Oh. So we do sometimes have people have seizures while they're having a PET scan,
yes.
and those do sometimes have useful information. But often what happens is that the increase during the seizure is averaged out with the rest of the 40-minute study, and you don't get useful information. So the first is logistics. It's just not practical. The second is when you are fortunate enough to have someone have a seizure in the PET scanner, often the acquisition is so long that you lose the signal. Did that answer your question?
Yep. You mentioned a functional MRI, and we can come back to that if you want, but also another one is magnetic resonance spectroscopy, or MRS. Is that used very often in epilepsy, or no?
You are springing things on me. So magnetic resonance spectroscopy is one of, remember we said you can do clever tricks with the MR signal? Mm-hmm. So magnetic resonance spectroscopy is one of the clever tricks that you can do. So we said that brains use oxygen and glucose, and that's correct. But neurons or brains, I mean, they're very complicated chemical factories. There are a lot of metabolic pathways, and in some conditions or in some states, you see changes in the chemical composition inside a cell, inside a neuron. So, for example, most people have had the experience of running for too long, and your muscles are sore afterwards. And some of that soreness relates to an increase in lactic acid. So you can actually use an MRI to take a picture of the brain and ask the question, how much lactic acid is there? Is there a normal or an increased amount of lactic acid? And that might have implications for what the brain function is in that area. So MRS is done usually in an area of the brain. You have to decide which area. You make a virtual box around that area. It's usually a small box, about maybe a half an inch on all dimensions, so a cube that's half an inch in all dimensions. And you would say, within this cube, what's the chemical composition? And that was, so it's a very interesting technique. It has found limited application in epilepsy because the results, while the results are interesting, they haven't added anything to the other MR techniques that are used. That may change with higher field strength magnets. So there are now 7 Tesla and 10 Tesla magnets, and the spectroscopy images you get at those higher field strengths are completely different than what you get currently. And it may be that at those higher field strengths, that technique becomes more useful.
Okay. So we've covered a lot, and I just want to ask if there are any other diagnostic tools that you think are worth mentioning, or that are used fairly often in epilepsy, or that are promising, or that are on the horizon.
Well, we should mention fMRI, right, only because I think it's something that some of your patients may encounter.
Okay.
You all know what fMRI is, because you've all seen in the newspapers or the magazines these pictures of a brain that looks like an MRI, and then it has a colored blob on it, and you know, it will say this is the brain thinking about love, or this is the brain when it's speaking. These colored blobs appear on the brain. That technique is usually functional MRI, and what it's doing is something very similar to PET, but it's doing it all with the same machine. So when you take your MRI picture, you can then slightly change what you do and get a functional map as well as the structural map. And you will know you're having a functional MRI if people are asking you to do things in the scanner. So usually what you get told is, stay still, hold your breath, don't move. But sometimes what you'll be told is, look at this crosshair, move your right hand. You'll be told to do things. And if they're telling you to do things, it's because they're taking a functional picture. And that functional picture is detecting very small changes in blood flow associated with doing that task. So remember, we already said that when a part of the brain is active, it uses more oxygen, uses more glucose, and it has increased blood flow. What functional MRI does is it pays attention to very small changes in oxygen concentration and blood flow, and it makes a statistical map of where those things change. And that it's an increasingly important tool for epilepsy surgery planning. or in fact any kind of neurosurgical procedure. Increasingly here we're using language maps and motor maps and sensory maps before we do tumor resections, for example. And we're doing it routinely before we do any epilepsy surgeries. And it's something that many patients will encounter as they go. It has advantages because it's not a nuclear medicine study. It means you can do it time and time again. And because it's not a nuclear medicine study, you have the luxury of repeating it for as long as you need to get a nice signal. There are no additional injections. So it has advantages, and increasingly is something you'll see when you come into hospital for studies.
Okay. I have a question. When you're talking about PET and functional, you keep hearing that cells have calcium, and that they think that the calcium concentration in cells and other things are what is causing a seizure. Do any of these things check for that and help with the development of drugs?
Good question. So functional imaging has not been used directly to influence drug development. The one area where that might change is if we find a good way to image GABA, which is an inhibitory neurotransmitter in the brain. People have been toying around with different ways to image that well, and if we could do that, that probably would be useful because some of the newer drugs act on GABA, and if you could take a picture and show that the drug meaningfully affects GABA and how it affects GABA, that might be useful both for drug development and for how to use the drug in a patient. So one of the frustrations patients have, but also your doctors have the same frustration, is we don't know which drug is the right drug for a person, and we don't know what the right dose is. We try and make intelligent choices, but it's very frustrating. It would be wonderful if you could give a drug to a person and then do an imaging study and say, this is the right drug for you, or this is the right drug for you, but I think you need a slightly higher dose, rather than waiting for the person to have a seizure and then tell them they need a higher dose.
Yeah.
That's interesting, because I've been put in the hospital and everything, studied my medications for me and everything.
And then the only other test we haven't talked about is a very specialized one, which is called a WADA test. It's reserved for people that are going to have epilepsy surgery, and it's an angiogram test. So just like a heart angiogram where they do a heart cath study, this is a brain angiogram study, and it's done to try and be sure which side of the brain serves language and which side of the brain is important for memory. And it's done to make sure that epilepsy surgery isn't going to hurt one of those things.
Yeah.
I have just a couple minutes left, so does anyone have any other questions about diagnostic tools or neuroimaging or any of the things that we've talked about?
Not really, no. I know I'm going to look for a new doctor that can give me some answers.
Right.
Okay.
I just want to say,
maybe. Yes.
Glynn, this was an excellent presentation. Thank you very much for all your knowledge.
Yes, this was really awesome.
You're very welcome.
Yeah.
Right. It's one of the things I enjoy is talking about it.
Okay. I did have one more question. People can hang on for a couple more minutes. But a lot of people with epilepsy that we talk to on the phone don't know necessarily what type of seizures they have, and even fewer know what type of epilepsy they have. And as part of this diagnostic process, what should patients expect from their doctors in terms of being able to tell them what type of epilepsy they have? Obviously, it's not always possible to come up with a specific epilepsy syndrome, but what at a minimum should they expect from an epileptologist in terms of telling them what type of epilepsy they have?
Yeah.
It's difficult to speak to specific cases, but on balance, if someone's had one or two events, it can often be quite difficult to give the patient the answers that they want, not for lack of trying.
Okay.
But conversely, if someone has frequent events, you should know the type of seizure that you have. You should know the type of epilepsy that you have, and those are termed slightly differently. And in some cases, we even call them epilepsy syndromes, meaning that we recognize enough things about you as a person that you have in common with some other people that we're able to tell you, for example, what medications tend to work well, whether your epilepsy is expected to go into remission, or whether it's expected to be something that you'll face for the rest of your life. We're able to tell you some other things about inheritance of epilepsy. So when someone's had only one or several events, I think it can be frustrating for everyone involved. When someone has had more than several events, there should be answers forthcoming about the type of seizure, the type of epilepsy, and in some cases an epilepsy syndromic diagnosis. You should know something about why you have seizures, but the question you often ask will go unanswered. So why, doctor, do I have seizures is a question that it depends how you count, but in probably 50% of people we can't answer that question the way you want us to. And when we can answer the question, it's a bad answer. So, the reason you have seizures is because you have a brain tumor. That's diagnostically satisfying, but it's terrible for the patient.
Yes.
So we understand chemically and electrically why people have seizures. We often can't tell you why you as a person seem to have those chemical and electrical differences compared to other people.
Okay.
Thank you.
And I think, you have to be comfortable with your doctor, be sympathetic that your doctor, for all kinds of reasons, doesn't have the information that he or she wishes they would have in terms of how to pick medicines and how to make you better. But you should feel comfortable that they're trying. And if you're not comfortable, you should get a second opinion.
Yes.
Yeah.
Okay.
Well, thank you so much for what was an excellent discussion, and I certainly learned a lot, and I hope everyone else did.
I know I did.
Right. So thank you, Dr. Glynn, and if people have any follow-up questions, you can certainly contact me, and either by email or by phone, and I'd be happy to try and find those answers for you. But I think we learned an awful lot, and we did record this, so we'll be able to share this information with others as well. So thanks again.
Great. Thank you, Russ.
Yeah.
Thank you. Take care.
Yeah, thank you.